and we will start in 1 or 2 minutes. Again, thank you for joining our webinar series today. For those who will require interpretation services are available through the globe. Bonjour et bienvenue. Nous allons commencer dans quelques instants. Nous donnons quelques minutes à d'autres participants de nous rejoindre. L'interprétation est disponible via le globe. Hello, everyone, and again, welcome to our second webinar titled Evidence-Based Risk Communication and Community Engagement Strategies. I'm Dr. Danielle Thomerson from the IFRC. I will be your host today. Good morning, good afternoon, and good evening for wherever you may be listening from. We will first start with the housekeeping. I hope you and trust you are hearing me well. First launching on behalf of our colleagues and planning committee from the IMST, the Incident Management Support Team, with Africa CDC and WHO. And this is also a co-convene with the Saving Lives and Livelihood Program, a partnership program between the Africa CDC and the MasterCard Foundation. We will set off our webinar today starting with the WHO Code of Conduct. The WHO is committed to enabling events at which everyone can participate in an inclusive, respectful, and safe environment. WHO events like these are guided by the highest ethical and professional standards, and all participants are expected to behave with integrity and respect towards all participants attending or are involved in the WHO event. As I have mentioned earlier, in terms of housekeeping, interpretation is available in English, Arabic, and French. Please kindly use the globe button to select your preferred language. Please use the Q&A for questions regarding the topic and presentation. So the Q&A button is specific to questions you would have for our speakers on the topic of today. Please use the chat and continue to use the chat as you have been doing to introduce yourselves or to raise any IT issues, including any issues with your translation channel. And in the Q&A section, you will also, when we have a Q&A portions of our webinar, you will be allowed to raise your hand and you can ask your questions directly coming off of mute. Now, what we will allow me to also translate quickly in French. Nous avons un service d'interprétation disponible aujourd'hui, anglais, français et en arabe. Donc, s'il vous plaît, veuillez cliquer sur le globe d'interprétation. Choisissez la langue de votre choix et vous pouvez supprimer le son original si vous le souhaitez. L'ensemble de cette session aujourd'hui est prévu en anglais, donc veuillez utiliser les canaux d'interprétation de votre choix. I will go back to our housekeeping and remarks. Kindly note that this meeting is being recorded, so please, as you're participating and attending this meeting, whether as participant or whether as panelist, we take your attendance as a permission to record your contributions and share the recordings via various channels for continuous learning purposes, including the IACO platform where you registered. The session materials, I know many may ask, so let me start by saying that the session materials, including the session recordings, will be shared with the participants in the few days following the webinars. You may have had to register or fill a few surveys. Please be sure that assured that the Project ECHO collects registration, participation, question and answers, even chat comments and poll responses for this webinar and shares them with the WHO. Your individual data will be kept confidential. These data may be used for reports, maps, communications, surveys, quality assurance, evaluations, and to inform new initiatives. So our agenda for today then. We've gone through the housekeeping, and shortly we'll see some of our speakers' bios and introduce our support team. We will have icebreakers and polls throughout the webinar of today. So please participate and answer. There are no wrong answers. This is the objective of today. To address any key gaps and have your questions come in through the chat and Q&A. So your active participation is actively encouraged. We'll have the objectives setting the scene of the session of today by myself. Then we will have our first speaker presenting on the use of evidence to drive RCCE strategy design by Yves Stéphane Galleux. Then we will stop to take your questions. We'll have a first Q&A session. Then we will have Sheila Mboise presenting on evidence from feedback mechanism and social listening to inform RCC strategies and decision making. And then we will take question and answers specifically for Sheila's presentation. We will also take time to ask our panelists a few questions that you may still have. And then we will end in terms of summary and closing remarks. And so Yves, I've mentioned Yves Stéphane Galleux with over 10 years of experience. Yves today represents both the IFRC and the RCCE collective services. Yves works to empower communities to navigate health crisis through effective risk communication and engagement. And we also have Sheila Mboise, from the Africa CDC. Sheila is a Regional Risk Communication and Community Engagement Officer at the Africa CDC, Eastern Africa Regional Coordinating Center, and has over 17 years of 17 years of rich experience in health promotion, knowledge management, and project management across Africa, and supports 14 plus African Union member states. And myself, I introduced myself earlier. I am Dr. Danielle Domerson with the IFRC. I'm the Health, Knowledge, and Learning Lead for the IFRC, supporting the Saving Lives and Livelihood program. A pleasure, an honor to be with you all today. We will have our first poll, quick questions for you all. Please take a few minutes to answer. You should see a prompt appearing on your screens. And the question is, what is the primary reason for using evidence to guide risk communication, community engagement strategy design? What is the primary reason? I see 14, 16 answers so far for 51. As soon as we reach a bit more than half, $28, few more. Great, we have 31 answers, and we see their selection across, and with overwhelming responses for all of the above. And as we delve in today's content, we will fully flesh out these answers. But yes, all of the above, and we'll see why together today. I believe we can stop the poll for here, and let's continue our yes, for today, we have our session more specifically looked at enhance of course, the title RCCE in evidence, or evidence-based RCCE strategies. And really the aim today is to enhance understanding and application of evidence-based risk communication and community engagement strategies. And this to be done across epidemic, pandemic cycle, from preparation, response, and recovery. That also includes a focus on immunization program. And will also provide key examples of RCC evidence as applied to these cycles of epidemic and pandemic preparedness, response, or recovery programs. So these are the main objectives for today. Oh, sorry, I'm still muted. Oh, sorry, I was muted. So then, let's take a moment to look at this topic and why we are covering this topic today. I hope you can still see my screen. I'm sorry, I might. So let's stay off the screen for a little while and look at, let's just imagine a tree. Not just any tree, but one that stands tall at the heart of a community. Its branches stretch wide, providing shade, providing food, providing shelter. But its strength really doesn't come from what we see above the ground, those trees, the tree, the fruits, or the leaves. It comes from its roots, deep, interconnected, nourished by the soil of trust, by the soil of ethics, and by evidence. And this is why, in so many ways, our RCCE, risk communication and community engagement work, is similar to that tree. And we'll see why together. Today we'll look at many sources of evidence. We will look at evidence from different sources, from different angles, and Eve and Sheila will be extensively covering this. And we'll see that that throughout. So that's not the issue. Thank you for projecting, as my screen has dropped me. So we will have, thank you so much, Alina, for the support. So looking at the roots, we were mentioning the roots. The roots are the foundation. There's various data and information sources. The data collection methods that we have will allow us to listen deeply and respectfully to the communities, to the persons, and gather that data. And that data is collected taking into account ethics and protocols that guides our way of doing research and collecting data and evidence. These protocols will also guide our engagement, how we research or assessments that help us understand the field, that help us understand the context. The roots are maybe invisible to many, but as we dive into the essentials, we make a proactive effort of understanding and seeking out that data. These data points and evidence and information are essential. Without them, our strategies, our approaches, our tools risk being uprooted by misinformation, by mistrust, or misalignment with community realities. And this is why these evidence, these data points are key. The trunk of our tree, still keeping with our tree metaphor, the trunk represents our response planning, how we use that evidence, the insights, to inform planning of either institutional work or community level work. And that planning needs to be structured, and it is there to support the weight of our action. Any decision making at again, like I mentioned, at both institutional or community level. This is where we have evidence to inform strategy, to inform policy, to inform national mechanisms. And this is where also coordination is key and remains critical. That ensures that our interventions are not only timely, but they are tailored to the needs and the voices of the persons we serve. And through our branches, we see in our top of the branches of the tree, as you're looking at the screen, you may see that our policies or strategies, really they're at the top of the tree, but really they cover the entirety of the work, and their core pillars, creating that policy environment that is needed to foster our RCCE work. So policies need to be ever dynamic, growing, really shaping policy direction through the evidence that we've gathered, and then adapting with the winds of change that are our community voices, of listening to our communities, and having that two-way communication is key. Feedback mechanisms having those continuous feedback and conversations in whatever form. Really, these are not a formality. It's the lifeblood of being adaptive, respectful as we go about our engagement and work in emergency or pandemic preparedness, response, or recovery. All of that is also supported as a key branch is our monitoring and evaluation framework, also informed by the evidence and the data we gather around programs, around content, around the community voices. Tangible, though we talk about monitoring as an intangible, but these are tangible and visible outcomes, the insights that we can harvest, the lessons that we share, the improvements that we make across the program, the approaches, the tools, the key messages. So these also continue to inform strategies, inform our work. So for all of us, either decision makers, either policy makers, either risk communication, community engagement practitioners, health promotion actors. This tree is way more than a metaphor. It is a model. It is making sure that evidence-based RCCE strategies is not a technical exercise. It's a strategic imperative. I repeat, it is a strategic imperative. When policies are rooted in community realities and nourished by ethical research and feedback, they grow stronger, they grow more inclusive, they're more sustainable. And investing in these roots, investing in these data, investing in these proactive research and evidence gathering ensures that we have robust policies and supporting communities to and empower communities. So as we begin today's webinar, I'll stop here, but as we begin today's webinar, we'll explore how each part of this tree, from roots to canopy, from data points to strategy, we will see how then we best equip our listeners, our participants with more insights, tools, and shared experience that will help our collective work grow deeper, stronger, and more impactful. Let me say this as a parting message as I hand over to our first speaker. Every data point is a story. Every evidence-seeking protocol is a guide through our process, and every feedback loop is a bridge. Together, we can ensure that our risk communication and community engagement efforts are not only evidence-based, but also remain deeply human. Let's begin. Over to our first speaker, Yves-Stéphane Galleux.
Thank you, Danielle. Please, can you confirm you can hear me very well?
Yes, Yves, we can hear you very well. I understand you may not be able to come video, but if possible, so people can see you, and then you can continue perhaps.
Yeah, great. I hope everyone can see me, and I hope everyone can see my screen as well. Okay, great. Hello, everyone. So I'm Yves-Stéphane Galleux. I'm RCCE Collective Service Regional Coordinator. And as Daniel presented, we'll be talking about how we can use evidence to shape our RCCE response or our RCCE strategy. So before we go, I would like to give a heads up about what collective service is all about. So collective service is an initiative between UNICEF, WHO, and IFRC. Sorry. And this initiative has key strategic approaches. One of them is RCCE coordination. And here we aim to increase the uptake of health-seeking behavior by affected communities through the coordination of partners and government in the delivery of RCCE activities. The second strategy is about data for action. And here we are supporting evidence generation and use to inform policy, programming, and also decision-making. And the last one, it's about on-demand capacity, and also self-support. So here we build sustainable capacity for RCCE at the country level for prevention, preparedness, and responses. So countries and partners can always reach out to collective service to request for human resource support, and that can be done in person or remotely. So talking about the use of evidence to drive RCCE strategy. We all know RCCE strategy is all about putting community at the center of what we do. And for us to be able to put community at the center of what we do, there are many things we need to take into consideration. So what do we need to understand when we want to put community at the center of what we do? We need to understand people's preference for and the need regarding the access to information. What are their preferred communication channels? What are their preferred languages? What are the languages they speak in the community in which we are intervening? And as we are implementing, we also need to understand the evolution of the people needs and priority. We need to understand the system that are working and the services that are in place. And if these services exist, how are they accessible? We need to understand the trust in services, the trust in policy, the trust in information that we are sharing, that the government is sharing, that other stakeholders are sharing as well. We also need to understand the capacity that exists in that community. And we all know crisis always start and end in communities. So understanding the existing capacities of community members is very important for us. We also need to understand people's belief system, the social cultural norms, and the existing tradition in the communities we are intervening. We need to understand the individuals and the community knowledge and the available resources that we can at times leverage on. We also need to understand people's perceptions, attitudes, practices, and behavior. We need to understand existing social vulnerability and also inequality that exists in this community. It's also very important for us to understand the existing social networks, the informal and formal community leader structures, the power dynamic, the different faith groups, the civil society organizations, the local NGOs that are intervening in these communities. And for us to better understand this, it's very important as humanitarian worker to always look across the program cycle. And we know the program cycle goes from the needs analysis, from the needs and concept analysis to evaluation and learning. And in this, we have to go through some important steps like understanding the local context and the priorities. Once we understand the local context and the priorities, we'll be able to understand as risk communication and community engaged practitioner, what can be like the major landscape in this community. We need to support community participation and also action. By supporting community participation, especially in the designing and the planning, we make sure that we shape our RCCE strategy to respond to community needs, to adapt to the community. And in implementation and monitoring, we need to make operational decisions and also monitor the action plan as we go on through the involvement of community members. This can be involving them in the monitoring process. This can be putting in place feedback mechanism that permit us to listen to community members regularly. We need to also evaluate our impact and understand what are the learning that we can leverage on for future activities. And we need to reinforce community system through our preparation and also through the anticipatory action that today most of the organization put it in front. And as we are working to shape our RCCE strategy, we need to understand that we have various ways we can use to collect data. We have the qualitative and the quantitative method that we can use to collect data. When we talk about the quantitative method, we use this when we want to know how many or how often maybe people are doing something. And we mainly use survey and through this quantitative method, we are going to touch large group of people, and generally we're going to use structured questionnaires. And this can help us to test theories that we have about a certain situation. We can be thinking that community members are not trusting vaccine, but how do we do to test that? How do we do to better understand um, these? This can also help us to establish causal relationship between X and Y. This can also permit us to analyze. I mean, we massive data and in quantitative method that we use for data analysis. And the more representative the sample is, the more likely it can be generalized to a wider population. And we have various tools, various methods that we can use in the quantitative approach, especially for early phase of the response. And this can be sector specific. We can talk about the health, we can talk about the wash, or this can also be multi-sectoral. And it is very important when we are in an emergency situation and we use these rapid qualitative rapid um, analysis. And most of the time, it ended questions with specific data disaggregation. The next one is about knowledge, attitude, and practices. Generally, we'll be talking about the CAP gap, we'll be talking about the behavior gap. And yeah, we need to understand what people know and what people do. We need to understand factors that influence people's behavior. We need to understand barriers to propose activities, especially when it comes to communication channels and so on. And the third one is about perception survey. And within the Red Cross system, perception survey is being used regularly to understand the views on specific topics, to understand the level of satisfaction within our operation, within our RCCE intervention. And also, it helps us it is being conducted throughout our programs and our operations. And this permits us to understand how really impact communities. And we can use the probability or non-probability sample in the perception survey. And we can as well use closed-ended questions with some open-ended questions. Now we have the qualitative approach that we can use. And when we talk about the qualitative approach, this permits us to understand why and how people behave and why they behave this way. And this is generally not based on number. This is generally, this permits us to explain what we have observed, like looking at factors such as the cultural expectation, the gender roles, the ethnic and religious implication, and also individual feelings. And usually we use small sample size when we're talking about qualitative approach. And this provides data that are usually very rich and detailed. So here we have to understand why the qualitative approach is very important. They're important because they allow us to understand why and how affected communities or affected people cope with and are really impacted by an emergency. It is also important because it gives us an opportunity to listen to people. It helps us to start a dialogue, a conversation with affected people in an emergency situation. It can also help to build relationship, to build acceptance, to build trust among crisis affected population. And finally, this help us to better identify and support the local resilience mechanism for our response. So here are some tools that you can use for a qualitative data analysis or qualitative data approach. We have key information interview, we have observations, we have focus group discussion, we have participatory planning, we have social networking mapping, we have social media monitoring, we have community feedback, and there are many other tools that you guys have been using in your various operations. And when talking about how we can use data in, how we can use evidence to shape RCCE strategy, we also need to understand what is the data cycle. And when we are talking about the data cycle, we look throughout the program cycle. So we have the preparedness, we have the planning and design, we have the evaluation and learning, we have the implementation and monitoring. What we need to
One moment, colleagues, as we retrieve Eve, whose connectivity may have dropped. Yes, you're back on, Eve. Over back to you. We lost you maybe a few seconds ago. You are muted, Eve.
Sorry. Yeah. So I was saying that for us to better shape our strategy, we need to understand the data cycle. And in the data cycle, we start with preparedness. We need to understand the community demographic, the structure and power dynamic. We need to understand the belief system, the social cultural norms, the traditions. We need to understand the preferred and the most common communication channel. And I will insist on the preferred because generally we focus on the most common channel in the community, but we need to understand the preferred and the most common communication channel. We need to understand the vulnerability and the community capacity. We need to also understand the community trust. And how do we collect this data? We have several methods. We can use the data evidence system. We can use social network mapping. We can use key informal interview. We can use focus group discussion. But we also need to understand that we need this to strengthen the community system through our RCCE strategy. The next one is about assess and context analysis. Here, we need to understand the community needs and their priorities. We need to understand the belief system, the social cultural norms and tradition as well. We need to understand the social cultural norms and tradition mainly related to the hazard or to our program. We need to understand the community relation and the communication. We need to understand the vulnerability and also the community capacity. And we need to understand people perception of response and the different services. And how do we collect this data? We also use several methods. We use the data evidence system, we use the context analysis, we use mixed meta studies, we can use observation, we can use gender and diversity analysis, and we use this to understand the context and the local priority. That will help us to really shape our RCCE strategy. And on the planning and design, which is also an important phase, we need to understand the community needs and priorities. We need to understand the community beliefs, the perceptions, the feedback, the knowledge, the attitude, and the behavior. We need to understand, or we need to carry out a stakeholder mapping to understand what are the stakeholders that are intervening into that community. And here we have methods that we can use. We can use the mixed method study, we can use the data evidence system, we can use community resource and risk mapping, we can use focus group discussion. And this will help us to support the participation and also community-led actions. And under implementation and monitoring, what we need to understand is the community needs and priority. And also as we move on, we need to understand how these needs and priority are evaluating. We need to understand community beliefs, perceptions, feedback, knowledge, attitude, and knowledge and behavior. We need to leverage, or we need to understand the level of community engagement and also their satisfaction. And we can use various tools, various methods like the rapid qualitative research, the statistics survey, the social behavior trend analysis. And these will help us to make our operation and our strategic decision and also monitor the cost of the action as we are evaluating the implementation. And under evaluation and learning, we need to understand the community perception. We need to understand the impact of the community engagement effort we have been carrying out. We need to understand the level of community engagement and their satisfaction. And we can do this through the perception survey. We can carry out focus group discussion. We can do key informal interviews. We can do mixed method approaches. And these will help us to evaluate the impact of the implementation actions that we have been carrying out. And for you to have the different approaches, for you to have these different tools I have shared with you, you can go through the CEA Community Hub of I4C, where you're going to have the different tools. You have the CEA guides, and you have also tools that will help you to understand how to carry out the various surveys, how to shape your RCCE strategy. And you can have this under the CEA toolkit. We also have the collective service website, and this is a very rich resources I will invite you to visit regularly. Through the collective service hub decks, you can request for a support, to shape your RCCE strategy, to be able to understand how you're going to use data to shape your RCCE strategy, to shape the overall response in order for you guys to make sure you are really impacting communities that are affected. So this was what we prepared for you. Thank you very much for your kind attention. And I'm very sorry for the quality of the network. We remain open for your questions. And thank you. Over to you, Danielle.
Thank you, Eve. And while we take questions for Eve, we can start our poll while people type in their questions. Thank you so much, Eve, and thank you for the emphasis on balancing both qualitative and quantitative data as part of our risk communication and community engagement work. Both are important, and what a wide variety of options there are to complete the mosaic, the picture that is our community's perceptions and beliefs, knowledge and attitudes and practices. Please take a few moments to answer the poll while we sort through the questions that are there. Do we have all our polls answered? Please, gentle reminder, if you are asking, please use the Q&A button option. That helps us and the speakers sort through what are comments and also what are questions that would require to be addressed. Let's see other questions that we may have. Okay, Eve, a question for you. I'll translate quickly, though I know you can read it, but I'll translate for our speakers to take up through their respective channels. So Constant, I hope I'm pronouncing correctly, Constant Ndume, is asking what is the approach that one should have for a community where everything that comes from the government needs to be taken with a grain of salt. So means that that needs to be taken cautiously and not necessarily believed a priori. So Eve, do you want to take this first question?
Okay, thank you very much, Danielle. Yeah, so he's asking to know what approach we can use in a community where everything that comes from the government is very sensitive. So here we have many approaches we can use. We go with the most common that we use regularly in our various organizations. We can use the Red Cross and Red Crescent community feedback mechanism via Red Cross volunteers. This is one of the approaches we can use. We can use the UNICEF U-Report method, which is a rapid qualitative research method that permits people to just answer to question and answer via their phones, which is very easy. We can also decide to put in place a community perception survey. And remember, we said community perception survey permit us to understand views on specific topics and also the level of satisfaction of community members. We can also go with key informal interviews, targeting specific people to better understand. We can also use focus group discussion. And we need to keep in mind that when using all these methods, when we are disseminating our findings, we need to make it to be anonymous to protect the people who are sharing this information with us. And if we find out it's very, very sensitive for us to receive information, I think we can also use observations when we are in that community. So yeah, thank you very much, Danielle. I don't know, maybe other colleagues can add if I miss out something. Thank you.
Thank you, Eve. I don't know, Sheila, if you are willing to add on to that response.
Yes. Good afternoon, colleagues. So in regards to what interventions, so from the insights, from the data that's collected, then we'll be able to develop interventions or frame our messages relating to or addressing to some of the key concerns that the communities would have. So from that, what Yves has said, those are the data collection tools. But when it comes to developing interventions and also framing messages, now we then look into gain framed messaging, and that's what I'll be talking about in the next session. Thank you.
Thank you, Sheila. And I think both of your responses bring us always back to the communities. What would the communities trust more, their sources, their responses? So every answer does not come from us, comes first and foremost, even in managing delicate situations, comes from the communities. There's a similar question I'll ask to Eve, and also you can also complement Sheila. Is actually a question from the chat. I'm glad I was able to see it. Other questions, please put them in the Q&A so we don't miss out such insightful questions. And we have Vachel, I hope I'm pronouncing correctly, Vachel Harris Lake, WHO Liberia, is asking, what is the most effective approach to collecting data on culturally sensitive topics, such as men who have sex with men, MSM, which is especially relevant in the MPOX response. So Eve, do you want to go first, please?
Yes, Daniel, thank you very much. And Bashir, thank you very much for this interesting question and very sensitive question, because this is something we face in many countries like Cameroon. So I think the methods, and you ask the most effective methods or approach we can use. I will first go for focus group discussion, because it's very important to understand that these are group of people who generally it's not good to expose them due to some political context. So through focus group discussion, we can be able to have information from them. Through key informant interviews, we will be able to also have information from them. We can also decide to organize the gap survey, which is to understand the gap between what people say, what they do, and also what they actually do in the community. So gap survey is knowledge, attitude, and practices. So these are some of the approach we can use with this group. And we can also use the rapid qualitative research, but mainly focus on these cultural sensitive groups that we have in our communities. So yeah, Daniel, over.
Thank you, Eve. Sheila, did you want to add?
Yeah, sure. I'll give an example from Uganda. In the recent Mpox outbreak, especially around vaccination. So what the Ministry of Health did was embed behavior scientists who are able to, who understand the social norms, the culture, and are able to speak to the level of those key populations. So also integrating behavior scientists within the data collection and analysis, and also implementation of interventions is key and has been one of the success factors when it comes to Mpox vaccination in Uganda. Thank you.
Thank you, Eve. Thank you, Sheila. I see a few other comments, and we hope we can have time to circle back to the comments in the Q&A later on. But if there are no additional questions from our participants, thank you so much for these insightful questions. We'll move to Sheila and her presentation. Over to you, Sheila. While you set up, maybe we'll have one or two questions from our poll.
Oh, Daniela, should I?
Yes, just a quick, I think we'll take one question, and then you can, in the meantime, prepare to present. I think you're presenting on your end, Sheila, so you can prepare after this first question. Please, are requesting our attendees to take a few moments to answer the poll. You should have seen a prompt on your respective screens. A few quick questions. And we'll spend one more minute as we get answers. The first is a very good segue to your presentation, Sheila. First question is, which of the following best describes how feedback can be used to tailor risk communication and community engagement messages? Well, as soon as we reach 20 answers, I think we can end our poll and give it back to Sheila. Great, Sheila. You'll see our winner for now is the answer to that question is overwhelmingly, according to our participants, to adapt content to local concerns and rumors. And on that note, thank you all for participating. Back to you, Sheila.
Okay, so I'd like to check if my presentation is visible, if my screen is visible, and if you can hear me okay.
All set.
Okay, thank you. So just to introduce myself, my name is Sheila Mwebaze. I'm a technical officer for risk communication and community engagement with the Africa CDC. I'm based at the Eastern Africa Regional Coordinating Center in Nairobi, beautiful Nairobi. So today I'll be sharing on evidence from feedback mechanisms and social listening to inform RCCE strategies and decision making. But first, just to give you a brief background about Africa CDC and what our mandate is. So the Africa CDC is an autonomous health institution of the African Union that is mandated with the responsibility to promote the prevention and control of diseases in Africa. Our vision is to have a safer, healthier, and prosperous Africa in which member states are prepared to timely prevent, detect, and respond effectively to public health threats and outbreaks. And also we aspire to become a world-class, self-sustaining and agile institution that champions Africa's health security. It sets the African public health agenda and leads and coordinates continental efforts driven by a One Health approach. So in this session, we'll move from the theory to the practice. As we saw, Yves introduced the types of evidence and the tools for gathering them. I'll now focus on how evidence has been turned into tangible RCC actions. I'll share lessons from Africa and the humanitarian context and give forward-looking recommendations for sustaining feedback and social listening systems. So I want to show that evidence only matters if it leads to action. So social listening and community feedback are valuable, but the real impact comes when we use them to adjust strategies in real time. So social listening is a proactive approach to detect, to understand, and to respond to misinformation before it undermines public health efforts. We have a few examples on the screen here. One is, both examples are actually from Cameroon. There's an example of a polio campaign that was held in Cameroon, and mid the polio campaign, rumor tracking was conducted, and the insights revealed that there were misleading rumors and fears about the vaccine safety, so the safety of the polio vaccine. And these insights led to rapid changes in the messaging, which also restored community trust and uptake. So still from Cameroon, we also have a campaign that was conducted, so a yellow fever campaign that was conducted last year in July, from the 24th to the 30th. And also midway, the campaign insights, social listening insights, showed rumors on safety of the yellow fever vaccine. So in collaboration with the expanded program on immunization, UNICEF, both parties and other partners, they mobilized community leaders, yellow fever survivors, and local media outlets to counter this misinformation with accurate, timely information. So the trusted voices, such as the respected community leaders and the testimonials from the survivors, were key to building the confidence in the vaccination process. So also verified safety data was shared widely on both traditional media, but then also on social media platforms, ensuring that the public had access to facts and not fear. So this coordinated approach helped keep the campaign on track and strengthen the community's trust in the vaccination process. So from here, we learned that This experience highlights how vital social listening is in maintaining public confidence in vaccination efforts. So we can conduct social listening before we implement an intervention, midway, as during the intervention, and also following at the end of the information. So social listening, as I said, helps maintain public confidence in vaccination efforts. So by detecting and addressing misinformation in real time, social listening, it provides more than just a reactive response. It enables health campaigns to proactively shape public narratives and rebuild trust. So on the screen, you can see a group of people seated. So this was a social listening dialogue with religious leaders at a holy water site during Ethiopia's cholera outbreak this year. That's our team from Africa CDC in Ethiopia with the religious leader. So this was taken in May 2025. So the issue was that there was an outbreak of cholera in Ethiopia, and this outbreak also managed to, there was also an outbreak of cholera globally and linked to people that had traveled to Ethiopia and that had access to these holy water sites. So we were able to engage with religious leaders at the holy water sites and also some of the pilgrims who were attending. And these holy water sites are a pilgrimage site that attracts visitors from across the globe, where rituals such as cleansing with holy water are undertaken. The water is also consumed or used for bathing, for physical or spiritual healing. So like I said before, there were cholera cases out of Africa that were linked to this holy water in Ethiopia. So that goes to show you that it's important to also listen. So during outbreaks, it's important to listen to key people like but then, hello? Is there an issue with interpretation?
There was an issue with the channels. I hope it was resolved now.
Okay.
Alina, are we all set to continue?
Yes, please.
Okay, all right. So moving on to the social listening systems to address misinformation, it's important that we monitor the public sentiment. So we can use digital tools such as Talkwater, CrowdTangle, and even Twitter analytics to monitor vaccine concerns, rumors, and misinformation. This helps us to spot emerging issues early and to understand the public mood. Also, it's important to pre-bank false information, as you will see in one of the slides, one of the videos that I'll be sharing. So instead of only responding after misinformation spreads, we identify the myths early, and this allows us to craft corrective messages before false beliefs become entrenched and spread widely. So informing responsive communication is key. We need to adjust communication strategies based on our social listening insights to increase relevance and effectiveness of public health messaging. So this ensures our communication addresses real, current community concerns. Measuring intervention impact is very important, it's key. So here we track changes in public attitudes and misinformation over time. This helps evaluate the success of the interventions and refine strategies for continuous improvement. So by combining the digital tools, community-based engagement, community feedback mechanisms, we can act faster, we can build trust, and we can prevent misinformation from undermining our outbreak response efforts. So these are strategies that we often use in RCCE, mass media, interpersonal communication, we have community engagement, and we also use digital tools. So under mass communication, we have radio, we have television, or local newspapers, and these tools can raise awareness quickly, as will be shown later in an Mpox awareness campaign example from the DRC. So how we can integrate the insights, we can integrate insights to the radio and TV messages, and this can be adapted to address concerns around myths and misconceptions. So under interpersonal communication, so this would involve dialogues between community health workers, and they would have tools such as frequently asked questions and talking points, which would be developed with support or insights from social listening and community feedback. And this can also help engage hesitant groups. So under community engagement, would have still community health workers, would have leaders, religious leaders, peer mobilizers, who would then work together with the communities to address some social norms, some contextual concerns. So under the digital platforms, we have AI tools such as chatbots, social media, and the good thing with social media is that there are opportunities to have live Q&A sessions where we can quickly correct misinformation online in real time. So the key takeaway from here is that the most powerful results come when all these strategies are combined, guided by evidence from the feedback mechanisms and social listening. When it comes to addressing vaccine hesitancy and misinformation, as Yves had talked about, what kinds of surveys, we could do qualitative or quantitative. It's also important for us to combine our epidemiological data with the behavioral insights that we are getting from the analysis from the tools that we would have deployed. And we also add this to the feedback from social listening and community feedback mechanisms. So some of these assessments, like he mentioned, like the rapid assessments, would help us to understand issues around vaccine acceptance. So would identify reasons behind positive attitudes towards vaccination. For example, I can still give an example of Uganda. There is great demand for the mpox vaccine among key populations. So it would be good for us to use these tools to understand why is there this great acceptance, what strategies have prompted increased demand for the mpox vaccination, and how can other countries learn from this. So we can also look at reasons for hesitation. We can explore uncertainties and concerns that contribute to hesitation towards vaccination, and also look at reluctance, investigating the factors leading to outright refusal of the vaccine. But important also is to ensure that our RCCE teams have the capacity to collect this data, to analyze it, and also to be able to adapt the communications and interventions in line with the interventions. So this data provides essential insights into the barriers and drivers of vaccinations behaviors, so helping to inform tailored and targeted strategies to improve acceptance rates. So as we all know, vaccine hesitancy and misinformation are quite complex challenges influenced by trust, by cultural norms like we saw earlier, and access to accurate information. So I'll share with you a few strategies that are designed to respond to local context while promoting trust and uptake. So we have tailored culturally relevant campaigns. Here we need to adapt messages from the community feedback and social listening to address the cultural and social norms as well as language needs. And it should also focus on benefits and community protection and collective action. Under building trust through engagement, it's important for us to maintain open dialogue with communities to build long-term trust. We need to use community forums, community dialogues, surveys, focus group discussions, as had been mentioned previously, for real-time feedback and myth busting. And we can also establish transparent communication channels that acknowledge concerns. Our vaccine champions as community liaison, sometimes these are trusted leaders in the community. They could be the community health workers, they can be peers, they can be religious leaders, political leaders, can be trusted to collect this data at the grassroots and also support in amplifying community voices in vaccination initiatives. So around, somebody had, I think one of the first questions that we had were around how do we address, it was around, I think, something to do with messaging. So I had also mentioned around using gain-firm messages, emphasizing the benefits to the community, especially, I think, yes, it was a question around how do you approach communities where that are sensitive on government or government initiatives. So again, listening to their concerns as a community, and then crafting messages and intervention which are framed around their benefits, community protection, and collective actions would help push that forward. So here I would like to share a video with you. And this video was developed by the Continental Mpox IMST RCCE pillar. So the Continental Mpox IMST is a collaboration between Africa CDC and World Health Organization, along with other partners like IFRC, UNICEF. We have IOM as part of that RCCE pillar. So at the start of the Mpox outbreak last year, around August, there was social listening that was conducted by the Africa Infodemic Response Alliance. And the insights from this social listening included a lot of misinformation, misconceptions around Mpox. And together we were able to develop some short videos that were posted online with Africa CDC social media channels. And these videos were able to help us debunk some of the myths. So I'll play the video just now.
Mpox is a disease caused by a virus that has been known since 1958. COVID-19 vaccines are used for the prevention of COVID-19 and do not contain any ingredients related to Mpox. There is no relationship between Mpox disease and the use of COVID-19 vaccines.
Okay, so this is an example of how real-time social listening can lead to rapid, targeted communication products that counter misinformation before it spreads further. We have a number of these videos in the series, and we are happy to share them with you, and also share the links on our website and social media channels. Okay. So still under vaccine hesitancy, we have a framework called the 5C factor. So, and this framework helps us to unpack evidence-based frameworks like the 5C, help us to unpack vaccine hesitancy, and also to be able to develop interventions that are tailored and targeted and address the needs of the community. So when we try to understand why people accept or refuse vaccines, there are 5 main factors. The first one is confidence. So under this, we can see trust in the vaccine and the health system. The second is complacency, whether they think the disease is serious, and this goes along with low risk perception. And then we also have constraints, how easy it is to get the vaccine, this calculation, whether they like to weigh the pros and cons, and collective responsibility, whether they feel responsible for protecting others. So this approach was used often during the COVID-19 research, but can also help us in understanding vaccine hesitance for diseases like Mpox or routine immunization. So how social listening can come in, it can come in to help us detect, for example, under confidence, misinformation or mistrust in vaccine safety and effectiveness, and how this can be applied to adapt our messaging. We can use trusted messengers and transparent safety data. Under complacency, this would include comments downplaying the disease severity. And here we can share outbreak risk data and real life stories, including stories of survivors, stories of people that have been vaccinated. When it comes to constraints, and these could include things like access to the health facility, the distance to the health facility, even access to the vaccine. Sometimes you find that when people go to the health facility, their vaccine stock out, so that could also be an issue. or even timing of the vaccination. For example, when you're vaccinating key populations like sex workers, you might want to consider moonlight vaccination at the time when they would be available out on the streets on the different areas they would be. And here, as one of the things I was saying, adjusting the clinic hours, maybe adjusting the time for vaccination, and adding mobile outreaches to get closer to the community. Under calculations, people can ask for more information before deciding, and also this is also in line with people having to wait. They wait for a friend of theirs who will get the vaccine, and if nothing happens to them, there are no side effects, then they'll be convinced that they can now be able to take the vaccine. So here we can provide clear information, comparative risk-benefit messages. And under collective responsibility, this includes narrative showing I don't need to protect others, so we can frame our messaging around protecting our family, protecting our loved ones and community as a shared value. And we saw this also in the COVID-19 messaging at the time. So now I'll share with you two case studies or examples of how social listening and community feedback mechanism insights have been integrated into interventions. Here we have an example from Jimma Zone, Ethiopia. So this was a 10+10+30 radio campaign in Ethiopia, and it's a powerful example of blended mass and interpersonal communication. It was conducted in the Oromia region from October 23rd, 2020 to January 10th, 2021. It featured, so this is where the 10-10-30 comes from. It featured a 10-minute radio drama on vaccination, followed by a 10-minute community health worker discussion, and concluded with a 30-minute listener call-in segment. So this radio show was held weekly over several months and in the local languages. It targeted rural districts with low Penta-3 coverage. In terms of the results, the intervention significantly improved the Penta-3 coverage, vaccination coverage in the Jimma Zone, especially in the intervention areas, and increased this from 64.6% to 84.3%. The intervention improved caregiver knowledge and attitudes towards vaccination, and there was also a reduction in vaccine misconceptions, especially around safety and the side effects. The radio call-ins enabled direct correction of misinformation. So here we see some of the key factors for success are it was held in the local languages. There was always a culturally relevant storyline as part of the 10-minute radio drama. They had a 10-minute expert discussion moderated by a health worker, a trusted health worker. And there was also two-way engagement via the call-ins of the radio. So we had the feedback being given, so the community calling in, and then information being passed on. And it was consistent and repeated messaging that started from October in 2020 and concluded in January 2021. So another example is about the ongoing Mpox outbreak in DRC. And we've seen that social listening has been integrated at all levels. We've seen social listening fully embedded into Mpox RCCE planning from the outset, creating a foundation for evidence-based interventions. We've also seen multi-channel rumor tracking, so rumors being tracked via radio programs, community dialogues, and also social media monitoring was conducted, and this created a comprehensive feedback system. There was also adaptive response in the intervention, so weekly RCCE meetings analyzed feedback and rapidly adapted messages to address emerging fears. So for example, when the vaccination started, there were fears around infertility, but through this social listening, the team on the ground was able to craft messages, FAQs to address the myths and the misinformation. So under community mobilization, there was a community action cell model that will mobilize trusted local figures to conduct interpersonal communication through conversation. So all these tools are being deployed or implemented in the DRC as part of the mpox response. Now, quickly going to the challenges and the gaps, we found that there's data overload and underuse. We receive a large volume of social and community feedback data, but much of it is not systematically analyzed or applied in decision making. We've also seen fragmented analysis and reporting. Different partners collect and report data differently and leading to inconsistencies and difficulty in building a unified picture. There's also limited local capacity for digital and even non-online social listening. This we saw in some of the assessments that we conducted as Africa CDC in 5 countries last year. So many countries lack trained personnel, the tools, dashboards, or any other infrastructure to capture and analyze conversations effectively. This area, RCCE in general, remains underfunded, and sustainable, well-resourced community engagement structures are still missing, which limits reach and long-term impact. So addressing these gaps is essential if we are to turn social data into actionable insights that strengthen public health responses. So in terms of sustaining these feedback mechanisms, so these are recommendations. We need to embed social listening and feedback mechanisms across all RCCE phases, from preparedness to response and recovery. We need to embed social listening across, I've already said that. So we also need to sustain, to have feedback mechanisms embedded within human and technical capacity in the member states. So member states need to institutionalize social listening within their national health systems. They need to invest in the local capacity to analyze and act on data and ensure that these findings influence policy and funding decisions. So at Africa CDC, we have a few social listening and infodemic management workshops lined up for a few of the countries, and we hope that this will also contribute in a way. So transparency is key. Communities must see how their input leads to change to maintain trust. And we need to prioritize and act on local voices and insights. So to conclude, we need to link evidence with action. RCCE becomes more adaptive and responsive and trusted if we link evidence to action. So this is not just about COVID-19 or Ebola. These lessons can be applied to many health challenges as we are seeing in mpox, cholera, and they can also be applied to strengthen routine immunization. Feedback as a tool demonstrates how feedback loops should show communities they are heard. It promotes equity and makes interventions more effective. So from listening to action, this involves closing the loop by acting visibly on community insights and showing people their input shapes decisions. So we need to also strengthen systems that make RCCE evidence-driven and people-centered. So my call to action today is to make social listening and feedback mechanism an ongoing sub-pillar of RCCE and not just an emergency tool. There's an example still in Uganda. I'm sorry that I've been sharing a lot about Uganda, but Uganda does have a sub-pillar on social listening and evidence generation, and this sub-pillar is under the RCCE. With that, I conclude my presentation, and thank you so much for listening. And now I welcome your questions and reflection.
Thank you so much, Sheila, and for even tying even better the theory and the practice, and bringing even more theory in with the 5 C's factors, for instance. So congrats on a wonderful presentation, and we look forward to seeing the questions that may come in. So we'll please put your questions for Sheila. I see a few thumbs up. Yes, well-deserved applauses and thumbs up. Please keep your questions coming for Sheila. In the meantime, we will ask you questions, and we'll put up a poll while we wait to see if we have few questions. Oh, maybe even Sheila, this is a bit outside the scope, but I know you've been probably linking with the Africa CDC team and relaunching the public health in our in the public health risk communication community engagement communities of practice. So there is a question from Belinda asking if there is a work group or cluster of our RCC actors for all the countries, and if yes, how to join.
Okay, so yes, thank you so much, Belinda, for that question. As Africa CDC, at the onset of the COVID-19 pandemic, we did have a community of practice, continental community of practice that had also committee, and the community of practice was meeting regularly, trying to strengthen RCCE, especially around COVID-19. But with the change in dynamics and with also other outbreaks and also trying to expand the scope, we are working currently closely with the committee and actually the committee mainly and a few of our partners to expand the scope of that community of practice to include social behavior change, because at that time it was RCCE only. And we're also looking at also integrated health promotion as part of that community of practice. So once we've finalized with the new terms of reference, we'll be able to reach out to members to join. So for that community of practice, we usually have our health promotion directors at the ministries of health, but then we're also looking at trying to expand the membership. So the plan is also to have regional communities of practice. So in the East African region, we have 14 AU member states. So we have the East African community countries. We also have the Horn of Africa. We have the island countries. So we also very soon will be working on setting up a regional community of practice that's in line with the continental community of practice. I hope that answers the question. It's work in progress, but we'll be sharing the details soon. Yeah.
That is wonderful news, especially in light of the recent publications of the experience around COVID-19 that the PHRCC COPA published very recently. So looking forward to hearing more. I think I speak on behalf of all the participants and partners. I don't see a lot of other questions. Maybe while people sort their thoughts, we can go to our poll. So there are only a few questions here. So please, participants, take a few minutes to answer these questions. Including which of the following are a key strategy to address vaccine hesitancy? And then that's multiple choice questions, so that should go very quickly. And then which of the following best describe a gain frame message? Sheila mentioned in detail in her presentation gain frame message. So which one of the options seem to fit best according to you, our attendees? So looking forward to your responses. We can give a few more seconds. Once we reach 25 responses, we can go back, and please then, if you have responded to the poll, please take the time to ask your question or raise your hand if you want to come off mute. Raise your hand and ask your question on evidence-based RCCE strategies or the cases presented by Sheila. A few cases from DRC. I think I saw a few colleagues from DRC introducing themselves in the chat. There were cases from Cameroon. Great, we're over 34 plus responses. Great. I go to the Q&A. I'm not seeing other questions. So I'll start with one question for you, Sheila, which is, and it goes a little bit in hand with the question that was asked about MSM groups, etc. So can you also think of examples of best practice in terms of collecting evidence or gathering evidence for other hard to reach groups? I'm thinking of people with disabilities, for instance, with limited hearing or limited sight. So for instance, so can you think of maybe how to then creatively go about collecting data from these groups, or can you think of a few case examples? Over to you, Sheila.
Thank you. So in terms of collecting data from maybe the visually impaired, data tools could be then transformed into Braille, so that if it's a tool that they need to answer questions, they could be transformed into Braille so that they're able to answer the question. It's a closed-ended tool. But I think also some of these people with disabilities, if they're not hearing impaired, we could still have our key informant interviews or in-depth interviews, but of course with a trusted person. So it's always good to bring on, like I was saying before, the social behavior scientists, the social workers that work closely with these people with disabilities. I don't have any current examples, and yet I know one of the first jobs that I did after uni actually worked for disability immigration. So I do have that experience with working with people with disabilities, but offhand I can think of Braille. I know that there were some studies. There's a tool that we have called the Behavioral Social Drivers for Immunization tool that was developed by WHO and UNICEF. And I know that that tool was also used to collect data on COVID-19 among people with disabilities. So if we could go online, I think be able to find that study. But yeah, some of the ways of collecting data are still the tools that we're using, but how can we then leverage these tools and then transform them into ways that we can be able to reach people with disability? Yeah.
Thank you, Sheila. And I think you've also addressed a question that was asked very early on about how to address situations where false information is or wrong information is given by one of the many actors, and that was a question asked in French in the Q&A, and they were asking, once the false information is out there, how do you then navigate that situation? I think you've talked about preemptively, like pre-bunking, etc. But do you want to speak more about how to navigate once the information is out there, practically speaking, how to go about navigating that aspect of it, a bit outside of evidence, but what do you do with that evidence once it's collected in terms of misinformation, disinformation, etc.?
Okay, so in terms of, let's say this myth or misconception has got out, would still apply what I was sharing with you. Once we've collected the insights, would need to develop messages with the correct information. So if it's on vaccination, safety data, again, using testimonials from survivors or people that have been vaccinated. Religious leaders are well-trusted members of our society here in Africa. So engaging with religious leaders to also help in debunking the myths and misinformation, but they also need to be trained. We would also, depending on what target audience it is or in what group of people, using like their peers. So like the youths, you would engage the youths in health promotion, in debunking this misinformation or misconceptions, depending on where it's coming from, but I don't think it's always led. It's always good to involve the community aspect. So involving and also including things like interpersonal communication. Sometimes, depending on the nature of what the misinformation is, sometimes you might want to like we're showing one of the examples around the yellow fever, like use mass media, but then there are cases where you don't need to use interpersonal communication, so person-to-person approach, and that's where FAQs, talking points come into play, combined with, so these would be used by our community health workers or community health workers. Yeah, so it's a case-by-case basis.
Thank you, Sheila. Do you have closing remarks? I don't see any other questions, and we're a bit past our 90 minutes mark. Would you want to do a few takeaways and closing remarks before I do an official close and summary?
Okay, so my closing remarks are that we've seen that it's important that our interventions, our messaging are informed by evidence. It's important that we listen to the communities. They have the solutions. They know how to solve some of these problems. It's just that we need to listen. And also, we need to integrate social listening across the program cycle. We need to have it nationalized in our ministries of health, and also advocating for more funding for risk communication and community engagement in general. Yeah, and thanks to the participants for listening.
Thank you so much, Sheila. And I think with Eve's presentation and yours, I think we've covered well in depth the different aspects of evidence and its use throughout risk communication and throughout the epidemic pandemic response and recovery cycle. And really, we've seen so far what we can take away is that really we're using evidence for all aspects of decision making and strategy design, from messages to adapting or revising strategies. And I think that was well clear once we started. I think even the first question in the poll that we had today, and we were all in alignment with the importance of this, the evidence for all our work. As part of RCCE and as part of our planning and monitoring and evaluation systems, we have seen there are multiple ways of generating the data types, from social listening to CAP surveys and feedback mechanisms, and even complemented by epidemiological data, all of our different sources that can be used, and making sure that we can use all of these data for all our work and whatever we're working on, whatever approaches we're using, from mass media or interpersonal communication. All of it is relevant to our work. And really, as key takeaway, I think is also reflected in the questions, that the importance of having coordination. It's harder to catch the ball once it has already been thrown. So making sure that there's coordination around RCC activities, approaches, strategies, and messages with clear focal points, and aligning messages across partners, across stakeholders is also a key piece of where evidence should be used. And I believe I gave example of the weekly monitoring or regular monitoring at country level as part of an example tool. And really, it's been a pleasure having all of you ask some of those insightful questions around practical applications and working with hard to reach groups. RCCE is community focused, and making sure that all communities have a voice is key, and that we are collecting, analyzing, and sharing the data around our community's voices is key. And looking forward to future opportunities, peer-to-peer learning, communities of practice, along with other other opportunities in near future. It remains for me to thank all our colleagues that have been part in planning this second webinar series, from our IECO team that has supported from the platform registration to today, thanking our translators, interpreters that have made it possible for multiple language simultaneous interpretation and not have that language barrier today. And thank you to our speakers for their insights, their in-depth presentation. And thank you to you, our participants, our attendees, for your questions, your interest, for joining today. Mid-August already. We're very far along in our webinar series. So looking forward to our future series. We don't have the established dates for the next series, but we look forward to keeping you posted through the usual IECO, WHO, IFRC platforms. Thanking as well all the partners who have supported this webinar, and have a good rest of your day to everyone. Thank you and goodbye. We will leave the meeting open as participants answer the polls before logging off. We will remain online a few more minutes. Thank you, everyone. Merci, Youssef. Merci, Willam. Thank you, Willam. Thank you, Vashti, Jean-Pierre, everyone who joined today. Thank you, Eunice, Amadi. There's a question on the certificates. We will circle back. It's an attestation of attendance, and they should be ready soon. Yeah, we will hopefully update on the timeline. Not too long. Thank you, Vashti. Thank you, Krishan. I'm hoping I'm pronouncing correctly. Masego, thank you. Thank you, Rogers, for joining. Hello to the IFRC colleagues. Thank you, Emmanuel, for the kind words. Merci, merci au ministère de la Santé du Togo. Thank you again, everyone. Thank you, Alina. Bye-bye, everyone.